Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin.
We're talking SECOMBIT today, the SECOMBIT article. There was a 4-year update in Nature Communications here in 2024, as well as the original publication, which might have been JCO 2023. But before we do that, we'll just do some icebreaker rapid fires. James, we just came back from ASCO. What gets you to show up at an ASCO these days?
Well, obviously, if I get invited to do a talk, I would try to come. So that I came last year. The COVID thing, I suppose I got out of the habit for a few years. And then one year I actually did a talk as well from my desk wearing scrubs. So then I didn't go that year either. That was the one where I think Omid Hamid made some comment on social media about me wearing scrubs. Did you not know about that?
No, I'm gonna find it.
Actually, Jeff Weber can't stop talking about it. But that's a whole separate thing. Yeah. I mean, the slightly boring answer is it clashes with school holidays in the UK as well. Sorry.
Yeah. I was going to say, and also somebody has to stay back and run.
Yeah, no, but it does it because it's the same time every year, and there's always school holidays in the UK then, so that kind of makes things a little bit difficult. Whereas ESMO moves around a bit more, so it's a bit easier, and it's closer, I suppose, as well. But yeah, anyway.
Yeah. All right. Well, fair enough. Okay. Let's talk SECOMBIT. SECOMBIT is the sequential combination immunotherapy targeted therapy trial, cool name, that he came up with, that Paolo Ascierto has been really championing for a long time. His work goes back more than a decade, of course, in this area of sequencing combinations for BRAF-positive patients. So maybe a study design and a kind of a high-level takeaway?
Yeah, so I'm looking at the Nature Communications, which is the 4-year update. Randomized phase 2, 3 arms, about 70 patients in each arm. BRAF mutant metastatic melanoma. And I guess, the way I think about it, although SECOMBIT, I think, recruited or started recruiting before DreamSeq, we could check that. But anyway, the way I think about it is quite a similar study design. Ipi-Nivo, Enco-Bini, 2 different sequences. But the interesting thing is the so-called sandwich arm. And so we've talked about this before, but this is the idea where you have targeted therapy up front for a period of time with the idea of debulking the tumor, potentially increasing the immune fitness, if you like, of the patient, and then giving the immunotherapy. And I think that's a really interesting scientific approach. And then clinically, we'll maybe talk about this again in a minute. In clinic, who would you want to treat? And then in that arm, and this is the sandwich bit, you can then go back onto Enco-Bini after the Ipi-Nivo if you need to. Not everyone will need to, but if you need to. So that's the sort of, I think that's the top line study design. And then if we just cut to the chase, on the PFS and OS, and this is figure 1. Actually, the OS is fairly similar for all 3 arms, although the green and the red, which is arms B and arm C, do better than arm A, which is blue. Arm A being the patients who were treated with targeted therapy, then immunotherapy. But the PFS, there's definitely a difference there, and green and red are together and blue's significantly worse, which I think, to be honest, the PFS, that's what you would have predicted. And I suppose my take home here overall, I think it's consistent with DreamSeq. That's number 1, definitely. But my other take home is that the sandwich strategy is a reasonable strategy. It's not detrimental. I think, honestly, I would have hoped that the patients on the sandwich strategy clearly did best of all. That's what I would have hoped in this study.
I think a lot of people would have liked to see them do better, but for, maybe the duration of the fixed treatment we can talk about. But you said you would have expected the PFS of the sandwich and the immunotherapy first to be the same. Can you explore that a little bit more? I'm not sure I would have expected them to be the same.
Yeah, maybe expected is slightly too strong, but I mean, I think this is a randomized phase 2 trial. There weren't that many patients in it. I mean, my null hypothesis, I have to say, in my own mind, would be that I'm expecting them to behave similarly. I would have loved it if there was an improvement in the sandwich arm, but
that's what I have felt like. Maybe just getting that little head start with BRAF-MEK puts them out in front. And then so there was a part of me that I think would have thought, maybe the PFS would actually be better in the sandwich arm. I guess that's sort of what you're saying. Yeah.
Yeah. I mean, what can I say about this? I mean, maybe I'm just too harsh about the whole thing, in a sense that it's a nice idea. But actually, does that mean I'm going to expect? That's why the trial was done, as far as I was concerned, to really ask. For me, that's the big question, especially with DreamSeek. And I think, in a way, the question's still open in some ways. And we talked about this a little bit when we were talking about DreamSeek. And what's the correct strategy here? Is there a fixed duration? If so, what's the fixed duration? Does it change from patient to patient? Is there any smart way of doing this? Something cool might be to switch off on a PET or something like that. Like they do in lymphoma, in a sense that we're going to individual. But none of that stuff's easy. And this is a randomized phase 2 trial. How often would you be doing your PET scans? Let's say, because if you've got really bad melanoma with high LDH and your kind of your level of benefit, if you treat until progression is, say, let's say 3 to 6 months, which it probably is, you're going to be doing monthly PET scans.
Right.
So so it feels like, and I don't know if anyone's done that, but I suspect not. But it sort of feels to me the ideal thing here would be some sort of circulating DNA or other type of marker. Where
would you ever follow
where you can measure it.
Yeah.
Well, this is an
Would you ever
interesting
follow
question,
the
isn't it?
LDH, right? Like you take these high LDH patients with the BRAF mutation, you treat them. Would you treat them to LDH normalization? Would you treat them? I mean, is that a very basic way to look at this?
No, I think that's a nice. I mean, I use LDH a lot in clinic. I have to say, I really do. I mean, in the old days, I used to shrug my shoulders about LDH.
Yeah.
But actually, the person who, and of course, that's before we had any effective treatment. So you're just doing a test, which sort of potentially gives you bad news, and then you go and see the patient, and then what you say. But actually, the person who sort of turned me on to LDH was Christian Blank. I don't know if I told you this story before, but I remember. Have I told you this or not? So
No,
I remember it really clearly. Yeah, this is a long time ago, but I probably need to be a bit careful about what I can say in public. But anyway, I was on the phone to Christian, I don't know how long ago, and it was in the days of Ipi mono. And we'd had this kind of experience, I think, in clinic, all of us, the patients with high tempo, bulky, bad disease, really don't get much benefit, or if any, from Ipi mono. And Christian rang me up and he said, well, I've gone through all my patients that we've treated with Ipi mono, and James, if the LDH is greater than twice the upper limit of normal, they don't respond. And I said, oh, that's really clear cut, Christian. Let me just look at my patients. And so I remember exactly where I was sitting at the time. And so then I just manually went through all the patients that we'd treated with Ipi mono at the time. I don't know how many it was, like 50 to 100, something like that, and found exactly the same thing. And so then we published a paper, actually. Have you not read it? You haven't read this paper, obviously. But showing... No, you haven't. What?
The 2x upper limit.
But 0. Zero benefit. Not 5%, not 6%, not 4%. Zero in our practice. And actually, when it came to looking at Checkmate 67 subsequently, that very much informed my thinking about these high LDH patients, because I was worried from the start that we might see some short-term benefit, but I was really worried that the patients with high LDH wouldn't get durable benefit from ipi-nivo. So that's one of the reasons, we did that at the time. And honestly, at the time, another colleague who I won't mention, but someone who works in the US in Boston, actually sent a message saying they couldn't believe that this information wasn't out there at the time, and they wondered why. But now it's relatively sort of well accepted. But to answer, that was a long digression. To answer your original question, could you use LDH? Maybe, I think, is the answer, because you really do see on target, we all know this, on targeted therapy, you get LDH normalization usually quite quickly within a few weeks. There's various catches there, like making sure the LDH is because of the melanoma, because, there are other causes of a raised LDH. But I think if you've normalized your LDH, what I would probably do if you were designing a trial or something like that is probably ask for a couple of normalized LDH readings, maybe over a week or something like that, to make sure it's normalized. And then for me, that probably means you've got the patient into as good a place as you're going to get them, based on this very old-fashioned blood test, right, which is crude. Right. I'm not sure we still really know what it means.
Well, that was sort of how I was thinking about it. We're in the real world where ctDNA is lovely, but has its own sampling issues, right? ctDNA is 1 or 2 tubes of blood telling me about the BRAF status of tumors in the whole body. I mean, the very next tube of blood could be shedding it, but these two may not have, or vice versa. So that's a sampling thing. LDH shouldn't be as much of a sampling issue. I mean, it should be being secreted from cells undergoing necrosis and things like this, which could be from other causes. Absolutely right. I think the thing that's helpful with LDH is if you have a patient on surveillance and the LDH is normal, and then at their melanoma recurrence or metastasis, it's elevated, there's some comfort that they're tracking in the same direction. But we all have patients where the LDH, of course, is normal while they have metastatic disease, and where it does nothing to track. That aside, if I'm in the real world, and I hadn't honestly thought about this until now because I've treated patients with a fixed amount of BRAF/MEK, but I'm presupposing how much that fixed amount is, partly because I have to prescribe it. So I have to give them a month's supply with a refill or not, or plan for the next thing. But perhaps what I should be doing is checking, I've decided I want to give them BRAF/MEK. I got to go check my instinct and make sure this was on the high LDH patients, and then check that LDH, like you say, once a week or twice a week. And when I have a couple of normalizations, which should happen rapidly, then maybe consider the switchover. Maybe we're optimizing that immune microenvironment in a way that, whether it's IPI as a single agent or in combination, we're just making it more favorable for a response. And it's the real world thing that we all have. It's not a scan that you can't early time and get covered. It's not a PET scan with all its confusing reads and coverage issues. It's just an LDH blood test. Anyway, something to think about. And let's maybe in fact check, look at the forest plot on these studies.
Yeah, I was just going to say as well, I mean, that obviously not everyone has a high LDH, which is a good thing, but actually it's this is the group of patients where we're talking about induction therapy. By definition, they're the people with high LDH par excellence. So I think, I mean, I don't know if anyone's tried to do this or not, but it's a nice little idea, isn't it? And you could almost, if you're doing a bit of this anyway, you and colleagues in the US, you could almost retrospectively go back. If you're all routinely measuring LDH with your fixed strategy, you could go back and you could see, well, who's normalized, who hasn't, how quickly did they normalize, and then see if there's any relationship there for subsequent benefit from checkpoint inhibitors, although obviously it's retrospective and the numbers and so on and so forth. Anyway, so more on SECOMBIT, because it was in Nature Medicine.
Yeah, I mean, we don't see it in this publication. We don't see it in this publication. And I went back to the JCO publication just to make sure I, had that. But are you top of mind with the brain mets incidence data that Paolo's presented? It's fairly interesting to me, I think, because the other thing that comes up in these sequencing, especially as you nailed it, that PFS is similar, OS might be a bit immature for the sandwich and the immunotherapy first arm, but has hit its median for targeted therapy. Ultimately OS benefit we want to see, but we also want to make sure we're not just pushing disease into a brain mets evolution. He presented at a meeting or two in the last year the incidence of brain mets on each of these arms in the SECOMBIT trial, and then the survival after brain metastasis. But I don't see it in this publication, so I'm not sure if that's fresh data for you.
Yeah, no, it's not. Can you remember?
I'm just going to clock it here at 15 minutes that we might need to pause and break the podcast. I can pull it up really quickly. I've got the slides somewhere. Let me just see if I can get to it. Or what we could do? We could just say it. We could just say what I think I know and then fix it in the fact check. Like more precisely say what his data is. So what I recall from this data that Paolo's presented is that the sandwich arm actually does have a lower incidence of brain metastasis than starting with targeted therapy first. I'm just not recalling where it stood up against immunotherapy first. It might be, equivalent. And then the survival after brain mets also doing quite well with the sandwich approach. So, there may be there may be other reasons to consider a sandwich approach, especially if it's in a patient population where, brain mets is certainly going to be a concern. We think of it sometimes as these head and neck patients, sinonasal mucosal melanomas with a BRAF mutation. There may be something to think about. How do I, the inevitable poor outcome that I don't want this patient to have is brain metastasis. Is there optimization of how to treat them with these agents?
Yeah, and we've talked about it a few times now, but I think as we move forward, this is going to be a really a critical factor that we need to consider. So what about the correlative analysis? I mean, actually, I'm asking myself in a sense, aren't I? Because it was in Nature Medicine, and I guess that's one of the USPs. But they did quite a few different things in an exploratory correlative analysis. They looked for defects in JAK, baseline serum interferon gamma, and I mean, I wasn't really taking anything away from that in terms of anything that's clinically usable.
So we're looking at figure 2 here in that Nature Communications paper, and I agree with you. The JAK mutation story is about immunotherapy resistance and things like this. Tony Rebus and Roger Lowe, I think, had published some of this stuff. But it's such a small incidence in melanoma. So that, when you look at the at-risk table in the Kaplan-Meier curves that are showing the JAK3 outcomes, so that's figure 3, you see that JAK mutations are only found in a handful of these patients, less than 10% or so. So I don't know what to make of that. And then the confidence intervals are obviously wide for arm B in particular, goes all the way left to right. And then also, all of these are crossing. I don't know that there's anything ready to go, whether it's interferon gamma baseline status, whether it's baseline mutation status. I don't know. How do you interpret those correlative analyses?
I mean, congratulations to them for doing it is the first thing that I would say. But I think, unfortunately, melanoma, people have been doing this a long time now, trying to work out whether there's things that we can use either at baseline or at the point of progression that are really going to make a difference for patients in the clinic. And we still don't really have much to show. That isn't to say that people shouldn't keep doing this, but it's it's a complicated disease. It's cliched, isn't it? And I think particularly when people are progressing, my own view is that it's heterogeneous and it comes down to evolution in a sense, and it's very, very difficult to treat. And I mean, post-mortem data I think show that as well. These patients who've got progressive disease are, you'd refer to the sort of genetic landscape as a train crash, I think. So it's a truly difficult problem. And that comes back to brain mets a little bit as well, I think. Is that to me at least, brain mets are almost inevitable, I think, whether you can see them or not, for people who are kind of, refractory to treatment at the end. So still a lot to do.
I mean, we know that from the autopsy series in melanoma patients that asymptomatic or non-clinical brain mets are found in a high fraction, 70-80% of those patients. The question really with our modern therapies is, are we inducing that more, or are we protecting melanoma patients from that? I haven't seen a modern autopsy series in the use of our modern era of therapies. I don't know the answer to that.
Yeah, I think. Well, yeah. I mean, I think there's a few recent ones, but nothing like the historical ones, because most of the recent ones are doing sequencing, and so by definition, it's going to be relatively small numbers of patients. And this is very difficult work to do as well, to get fresh autopsies. Anyway, that's a bit of a digression, I guess.
Yeah. Well, anything else you think you want to say about SECOMBIT? Anything about talks or anything about outcomes?
No, I don't think there was much to unexpected or in terms of talks. I mean, my kind of headline here, I think, is that there's probably something in the sandwich strategy actually, and I think maybe it's worth continuing to look at it. And I think if we could maybe individualize it, I think we might then see that delta that we talked about in PFS earlier on. So I think there's something there. I just don't think we've kind of got to the bottom of it yet. But it's a fantastic study, and congratulations to Paolo and his colleagues in Italy for running it, because it's an academic study.
Agreed. This was really wonderful. And I think this was some fodder to get industry-sponsored EBIN study, the Oncobeni Ipi-Nivo study, which ended up, also comparing sequence but sandwich, and maybe just might have had a different duration of sandwich, but all coming from really this strong investigator-initiated work, which is incredible. I have the same instinct maybe that you're alluding to, which there is a portion of patients in whom the sequence of a fixed amount of targeted and getting over is going to land them on top of another sequenced regimen. And it's sort of, who are those patients? How do we actually pick those out and get them? And nearly impossible to design a trial just for those patients. But I think it's, we may have said this on this podcast before, it's going to be like pornography. You know it when you see it. You can pick out that patient who might need their targeted therapy for a fixed amount.
I don't think we have discussed that before, actually. No? But anyway, okay. That particular analogy.
Okay. Well, with that, that's a wrap on SECOMBIT. So thanks, James, for sticking with it.
Thank you.
I'm sure it got a little
better.
That
was exactly so right. That was.
Hi, everybody. Doing a fact check now for SECOMBIT, sequential combination immunotherapy and targeted therapy. Early on, you were saying there was a pretty humorous tweet that Omid Hamid had done about you wearing scrubs. I found the tweet. It's from September 2021 for anybody who wants to go look at it. And he's saying that you're rocking the scrubs. And there was some article he found that Turnbull and Asser had, I guess, started making the NHS scrubs. Anyway, it's cute. It's charming. It's you giving your ESMO discussion, it looks like. We were talking about enrollment dates of SECOMBIT and DreamSeq if it overlapped. And we know that DreamSeq is 2015. And I think we mentioned in this episode the enrollment for SECOMBIT. You had asked if I was familiar with that article that you wrote about LGH. Embarrassingly, I was not familiar. And this is lactate dehydrogenase as a selection criteria for ipilimumab treatment in metastatic melanoma. You and Christian are the senior authors. And this, if I'm not mistaken, was in Cancer Immunotherapy, Cancer Immunology and Immunotherapy 2000. I wrote the title and the authors, and I didn't pull the actual citation. Let's say 2013 or 14. Maybe.
Sounds about right. I can't remember.
Okay, good. This is like a half-ass fact check.
It's absolutely Christian's idea, to be clear, though. So it was a nice little paper.
A good part of the recording, I thought. That was a nice discussion about the role of LDH. There was also that question about how many, a fixed switch, SECOMBIT is a forced switch. So how many doses? Was that Arlene Sharp and Jen Wargo? How many patients did they look at to say T cells come in and then they go out? They were there by 1 week and they were gone by 5 weeks. Actually, it was one patient. I think you knew that very well because you were sort of saying you'd like to have seen that in more patients. It was one patient, mouse model, et cetera, et cetera. Anyway, so good to know. I feel like I had heard about more patients. Maybe I just couldn't find the publication. And then please teach us about this word par excellence, this phrase that you used in the podcast.
Yeah, I've just been thinking about how to define par excellence, but maybe it would be something that is the best example, or that's a particularly good example of something when you say par excellence.
I think you're right.
That's the best I can do. Yeah. But I've never even thought about it.
Well, you used it in this episode, so I need to go back and listen maybe. We were also batting around because I think you kept saying, well, it was published in Nature Medicine. It was published in Nature Medicine, and you were having a good chuckle to yourself. The follow-up, 4-year follow-up SECOMBIT was, I think, Nature Communications. The only relevance there being that there is a difference in impact factor in these two journals. Nature Medicine being, 58, 59. Impact factor, Nature Communications, still a wonderful place to publish, 15, 16. And then there was a comment, we were talking about CNS incidence in autopsy series, and we know that old data, but I wasn't sure if you had any information about a more modern series on that.
Yeah, so I think that our work led by Sapna, we've done some more modern so-called warm autopsy series with sequencing, basically, which I think is one of the main differences, from the historical series. And I think a citation for that might be a recent one. I think Lavinia Spain is the first author, and I think it was Science Translational Medicine last year. So, and Sam will be the senior author on that. So it's a small series, but I guess the point is, this is actually very difficult stuff to do logistically, and B, it's a sort of a more detailed take on that whole story, which I actually think is important. But maybe we could have a more detailed discussion about that another time.
I like that. Sequencing is cool because we were talking about just asymptomatic incidence of CNS Mets in the autopsy series. But if she's sequencing, then she can look for things like PTEN loss and correlate that even more specifically. Great. All right. That's a wrap on our fact check.
Weren't you going to say something about me being ill? No. Was I ill?
We can. I mean, the listeners know it, but you were really feeling poorly during that recording, it sounded like.
Was that the one in the farmhouse or not? Was that a different one? Oh, yeah. So I don't know. Maybe I had COVID or something. I've got no idea. But yeah, my data, my recovery data was just abysmal. So there wasn't another cause of it. So I think I probably was ill. There are other causes, obviously. Yeah.
You could hear it in your voice. I mean, it was like it was probably torture recording that. So thanks for doing it. All right. Thank you.
Yeah, thanks.